Hello, everybody, and welcome to today's symposium on behalf of Lionel Green Thompson, who you will see later in the meeting, and the Professional Standards Committee. I'd like to welcome you to the symposium entitled Treatment and Tool Stories, Research, Communication and Science Culture in the Time of COVID-19. In our panel today, we have four wonderful speakers who we are very privileged to have. They hail from all across the world, in fact. Our first speaker is Dr. Kate Webb, and I will introduce her in more detail at the beginning of her talk, who is based here in Cape Town and, in fact, at Red Cross Children's Hospital. Our next speaker is Daniela Jan, who is an author, writer, and educator and motivational speaker. Our third speaker is Dr. Anne-Marie Corriat from the UK and the Wellcome Trust. Our fourth speaker, joining us from the middle of the night in Australia, is Dr. Jane Munro, who's head of the rheumatology unit at the Royal Children's Hospital. Tanya, and then last but not least, Tanya Faber, who is a senior health journalist and science journalist from the Sunday Times. I will introduce them all more fully at the start of their speech, the start of their talks, and then at the end we're going to have a wrap up by Professor Green Thompson, and then an opportunity for questions and discussion. So during the course of the presentation, please put questions into, type questions into your question bar, send them along, and we'll collate them together. And then towards the end, we will have an opportunity to direct those at particular speakers and to the general group. So with that, I'm going to just introduce Kate Webb. So Kate is based here at Red Cross Children's Hospital and the University of Cape Town, where she's a consultant pediatric rheumatologist and laboratory immunologist, a rare breed. She was awarded a competitive action medical fellowship to complete her PhD investigating immune system interferon response in juvenile systemic lupus erythematosus at University College London, which she has completed. And she is published in this area, and her research has been presented widely, including at the Pediatric Rheumatology European Society, where she was awarded a Young Investigator Prize. She is currently supported by the Francis Crick Institute at the Crick as a Crick African Career Fellow, working on SLE and African patients in UK and SA. And during the pandemic, she's in fact provided clinical service and changed her research focus towards the Kawasaki-like hyperinflammatory syndrome in children associated with SARS-CoV-2. So Kate, thank you for agreeing to present to us this morning and to your talk entitled The Politics, Scientists, Publications and Retractions, the Wild Tale of Chloroquine in COVID-19. Kate, welcome.
Thank you very much, and thank you for having me. Let me just make this a bit smaller. Yeah, so let me just check that I can skip over. So our story begins in 1623 with the death of a pope in Rome. At the time, Europe was plagued by fevers of bad air or malaria, and a group of Jesuit priests were sent out, commissioned all over the world to search for a cure for these fevers. This was found high in the mountains of the Andes in the dried bark of the cinchona tree, which the active compound was found to be something called quinine. And this plant quickly became vital as a weapon in the armamentarium of empire and war. And it was widely planted throughout the world with access and supply routes jealously guarded. It was in the Second World War that a race ensued to make quinine into a compound that was tolerable to use as prophylaxis or to use in the long term, so that forces could not have soldiers become unwell and be taken away from the front lines. And ultimately, the Americans won out to distill it into a form currently known as chloroquine, which effectively prevented the scourge of malaria and has been used since then for various different indications. Chloroquine has a strange effect in that humanity seems to turn to it quite frequently when we're plagued by fevers of unknown origin. And it also has a knack of working in vitro culture models against many pathogens, including African swine fever virus, HIV, influenza A, chikungunya virus, as well recently as Ebola. But one of the things with chloroquine is very seldom do these in vitro culture successes translate into in vivo success of the drug. So similarly, during the initial SARS-CoV-1 pandemic, and this is a culture model in Vero 8 simian cells, where chloroquine was able to inhibit the replication of SARS-CoV-1 in culture. And very quickly on in this pandemic, chloroquine was tested along with a number of other compounds, and in vitro seems to have quite promising effects against the replication of SARS-CoV-2 along with remdesivir. So this led very early on in the pandemic to one of the first papers that I'll speak about, which was published by this group in France, including Cartret, Colson, Raoult, and Rollin, and in the International Journal of Antimicrobial Agents. So this was published on the 20th of March, which was relatively early on in the pandemic, where they looked at hydroxychloroquine combined with azithromycin to treat COVID-19. And they showed the results of this open label non-randomized clinical trial. They declared no competing interest. And what's interesting about this is it was received on the 16th of March and accepted on the 17th of March, which is most of us know is an extremely rapid turnaround for peer review. So they included 42 patients. Just briefly, I'll go through these data. 26 of them at this tertiary referral infectious diseases unit in Marseille received hydroxychloroquine. These patients also received a daily PCR test. 6 of them also happened to get azithromycin, and 6 of these patients were excluded. This included 3 who went to ICU and 1 who died, 1 who developed side effects, and 1 who left the study. And as you know, this is problematic. These patients should not be exclusions, they should be outcomes. You can't exclude patients who do poorly. The control group consists of 16 patients who did not receive hydroxychloroquine. These patients were at different centers in Marseille and Nice, so not similar to the comparator group. They didn't receive daily tests, and it included those who had refused treatment. There was no placebo, and it was not randomized. However, they showed that getting hydroxychloroquine and azithromycin made you more likely to become PCR positive sooner. So these patients became PCR positive, the proportion of them with PCR positive results, they became PCR negative sooner. So at day 5, all of them became PCR negative compared to those who got hydroxychloroquine alone and compared to those who were control. They then purported in the discussion reported that they thought these results were so good that they recommend that COVID-19 patients be treated with hydroxychloroquine and azithromycin to cure their infection, to limit the spread, and they further go on to recommend it as chemoprophylaxis to healthcare workers. And this was widely taken up and used across the world. Upon closer inspection of these data, and I'll just go through this very briefly, it very soon became clear that they were problematic. Up until the black line are the patients who didn't receive hydroxychloroquine. These are the patients who did up until the brown line, and below those received hydroxychloroquine and azithromycin. And as you can see in the group that did not receive hydroxychloroquine, there's a lot of NDs or not done. So these patients didn't have tests. Some of them didn't have tests for the first 3 days of the research, which begs the question of what the exclusion criteria were on day 0. Some of these patients were negative, and you can see in the red outline boxes, were positive. So this is a CT value of 24. They became negative, and then they became positive again. So it begs the question of how valuable is this test if you can become positive, then negative, then negative, then positive, and how meaningful it really is about whether your PCR is positive or negative. In addition, some of the patients' PCRs were reported as a delta CT value, so that's an actual value, and some of them reported according to an arbitrary cutoff as negative or positive. And more didn't have the actual value in the group that wasn't treated as opposed to the group that was. So these data very quickly came under scrutiny, and in reanalysis, which a lot of people did on the internet, if you use more stringent criteria and if you exclude those who didn't have a positive test on the first day, the significance of the findings became a lot less impressive. The other thing is the editor-in-chief of the journal is one of the authors, and one of the editors, Coulson, is also one of the authors. So this was not declared in the conflict of interest, and it begs the question of the 24-hour turnaround in review. Additionally, the data that was in the preprint versus the data that was ultimately published was different, and this is a difference in data from a YouTube video pre-publication entitled COVID Game Over, which had different data to the ultimately published paper. There was a problem with the timeline in terms of the fast turnaround in review, but also it was reported that this trial only received ethics approval on the 5th and 6th of March. So on the 16th of March, they had enough data to write a paper and to submit it, which is highly unlikely. Despite some of these questions very early on, this is the day after the paper was published, it was widely taken up with Donald Trump tweeting that this was one of the biggest game changers in the history of medicine, and that it should be widespread and that people should use this and be put into use immediately. And this hasn't really changed throughout the course of the pandemic. This only goes up to April the 4th, but even post that up to, I think, the 28th of June, we know that Donald Trump was still talking about the usefulness of hydroxychloroquine. Smaller papers started to come out thereafter, so on the 7th of May, on the 11th of May, and on the 14th of May, and these were smaller randomized controlled studies that by no means were robust, but started to show that there was probably not a significant effect. And then the pendulum swung the other way with the publication of this paper on May the 22nd in the Lancet, where they looked at a huge number of hospitalized patients with COVID, almost 100,000, and they were able to gather data for almost 15,000 of those patients who had received chloroquine, hydroxychloroquine with or without azithromycin. What they were able to show is that chloroquine, hydroxychloroquine, or the two in combination with a macrolide were associated with a significantly increased risk of ventricular arrhythmia and a significantly increased risk of death. And this was highly publicized at the time. This data used, and we're just going to use the African continent as an example because that's where we're based, 4,500 patients from Africa with COVID-19, and this data was gathered from a company called Surgisphere that was based in Chicago, who extracted these data from electronic health records of hospitals that were involved in Surgisphere. So at the time, this represented about 25% of all patients in Africa with COVID and about 40% of all deaths. And at this stage of the pandemic, the majority of patients with COVID were from South Africa. So this was highly questionable since none of us had heard of this company. And we all knew the trouble trying to get all of the data together at the early stages of the pandemic. And it was highly unlikely that there was a company that without ethics already had access to this volume of data. In addition, they spoke about the hydroxychloroquine use in Africa, and as a rheumatologist, we are not able to get hydroxychloroquine. We're able to get chloroquine, so this is all highly suspicious. As people started to write letters questioning these data, the initial authors, who are Harvard-based, asked their colleagues at Surgisphere to provide the data, and the WHO offered to do an independent review of the data. And when the data were not forthcoming, this was retracted from the Lancet. And a similar paper in the New England Journal of Medicine was retracted, who had looked at the same data in relation to ACE inhibitors and COVID. So this was swinging in the other direction. Then in June, the recovery trial saw no benefit of hydroxychloroquine and withdrew that arm. And in August, the NEJM published this this control trial, which was looking at post-exposure prophylaxis with hydroxychloroquine against COVID-19, which showed no benefit of hydroxychloroquine if you had been exposed to COVID-19. So it's really interesting how this pendulum has swung from hydroxychloroquine being a miracle drug and it being widely reported to be beneficial to being deadly, and then hopefully we think settling somewhere in the middle. What's important, though, is on the other side of the graph, you can see the timeline of media mentions of how prevalent the mentions of hydroxychloroquine were, but similarly the hydroxychloroquine shortages that were experienced by patients specifically with lupus. So I just want to introduce some of the concepts very briefly of how scientific culture may be to blame for some of this that's been going on and how the pandemic has brought this into stark light during this time. We want scientists to be open and supportive and to do their job with diligence, to be attentive to detail, to work slowly and thoughtfully, and we want them to be motivated by the answers and not by the papers. But what we've managed to do is create a culture where science is cutthroat, where scientists don't have access to permanent jobs, and there's a continuous instability of scientists. And it skews towards scientists and PIs from specific renowned institutes who are better at selling themselves and maybe more narcissistic and extroverted. People fake data, and it happens quite prevalently. This is a study that shows brain tissue, and there's people on the internet who look at these fake data. So if you can see in red, those are just cut and pasted, and people flip them up and flip them down. So what are the things that we can do to mitigate this? Well, there's moves towards data sharing, so that all data that I capture from people with certain diseases belongs to the public and belongs to the research environment. And many funders require this now that you have a data sharing plan. These get catalogued and made usable and put into public forums where patient privacy and anonymity are protected, but the data are available. This has many benefits in that if I publish certain data, there's other populations with similar trays and that data available, so it can be replicated and my hypotheses may be tested. It reduces us wasting research funding and reduces unneeded experiments and us not replicating things. If databases are out there for us to test hypotheses on, that helps. And also it makes data available to society, who ultimately owns and pays for the data. Open access is what the scientific world is moving towards, and I know many universities and funders are making this a requirement, that once your work is published, it is not hidden behind a firewall and becomes available to people. And open review is another concept that's being worked on, where we know who reviews papers. It would have been interesting in the initial paper that I spoke about to find out who was reviewing that, and the review becomes available and is published alongside the paper. And this is an example. Frontiers does this nicely, where we know who edited the paper, we know who reviewed it, and all of the data within that paper is available, so we can then reanalyze the data and test the hypotheses. So my favorite saying is the plural of anecdote is not evidence, and I hope that that talk has just introduced our future speakers and given them a platform to speak about that. Thank you very much.
Thank you, Kate. That was a fantastic introduction to the really kind of concrete implications of how COVID has changed the way we communicate as scientists, and how sometimes that can go wrong, or how it has often gone wrong in this particular context. And this leads on to our next speaker, who is going to talk to us from the other side about how this can impact real people with conditions who use medications that have been involved in some of these controversies. Right. So with no further ado, let me introduce Daniela Jan. She is an author and an educator with a background of having a Rhodes University degree in journalism and media studies, as well as psychology. Her book, Crazy Became Me, A Lupus Story, was published and launched in both Cape Town and Ghana in 2018 and 2019, respectively. Crazy Became Me, A Lupus Story is an educational and insightful memoir of her experience of living with lupus herself. She has recently written the first literary book for children with lupus in sub-Saharan Africa. The book is entitled Wandile, the Warrior on Woes, is part of the Loopy Kids project run by Andrea's Gift Foundation for Lupus Support, and will be the first of its kind in South Africa. She aims to launch the book on World Young Rheumatic Diseases Day in March 2021. Danielle is part of the board of Andrea's Gift Foundation and has become an advocate for spreading awareness on this autoimmune disease. She has been a representative for lupus on various platforms in South Africa and Ghana, and we're very privileged to have her here today using her powerful voice to talk to us about the experience from the other side. So Daniela, welcome.
Thank you so much for that introduction, Professor Donald. Good afternoon, scientists and staff at UCT. My book, Crazy Became Me, A Lupus Story, has fortunately opened many doors and given me several opportunities to promote awareness and understanding of lupus. This symposium is one of such opportunities, and I am honored to have been invited to speak and share my views, as well as the views of my fellow lupus patients whom I represent. Next slide, please. My initial reactions to the political endorsement of chloroquine as an effective treatment and prophylactic agent for COVID-19 was somewhat conflicted. On the one hand, I viewed it as a way of shedding light on patients who depend on the medication, therefore increasing much needed awareness of lupus. On the other hand, I was concerned whether the sudden popularity of the drug would negatively impact my access to the medication. Next slide. My concerns were justified, as not long after the media reports and the announcement of clinical trials on chloroquine in many countries, including South Africa, the medication ran out in many pharmacies nationwide. This created a deep sense of anxiety among lupus patients. Firstly, because not having access to the medication we depend on would further affect our already compromised immune systems, increasing risk of illness or flares. Next slide. According to Dr. Michelle Petrie of the Johns Hopkins University School of Medicine's Lupus Center, mortality increases fourfold if a lupus patient stops taking chloroquine. Secondly, our concern that the price of chloroquine, which is relatively cheap, would hike because of the sudden hoarding to treat COVID-19 patients in the developed world. Next slide. In a March 23rd statement, SAHPRA, the South African Health Products Regulatory Authority CEO Boitumelo Sumeto Mokokutela, said preemptive prescribing of chloroquine was leading to fear-based stockpiling of potentially life-saving medicines and was a serious misuse of the drug. As part of the Andrew Skiff Foundation for Lupus Support, I reached out to Mrs. Sibongile Komati, the founding director of the Lupus Foundation of South Africa, to intervene. She was in contact with health officials and a petition was circulated across social media platforms appealing to the government to stop the dispensation of chloroquine to patients who were not dependent on the medication. Unfortunately, not enough patients signed the petition to receive any attention from government. And although the Medicines Control Council said they would get back to Mrs. Komati, to date they have failed to do so. Next slide. My particular pharmacy ran out of chloroquine in April, and I was therefore forced to take 3 tablets a week, as opposed to 5, to stretch it until they were able to access the medication a month later. Although SAHPRA called on doctors to stop prescribing the medication to prevent infection with the new coronavirus or to treat the disease it causes, doctors allegedly still prescribed the drug, and pharmacists were obliged to dispense it. Next slide. I conducted an informal survey on social media platforms to get the patient's perspective on their access to chloroquine during this pandemic. The survey featured 13 public patients and 19 private patients across South Africa and posed 3 questions. Next slide. Number 1, during this time of COVID-19, have you been able to get your chloroquine? And if not, what was the response of your pharmacist or doctor? Number 2, how have the medical or scientific community been communicating with you during this pandemic? And thirdly, what can they do better? Next slide. 62% of the public patients had a negative experience where hospitals ran out of the medication with no backup plan. Many of these patients went without chloroquine for months or were forced to search multiple pharmacies that had stock. 63% of the private patients, however, had a positive experience, saying that although many pharmacies had run out, they had deliberately kept some for their lupus patients. Less than 10% stockpiled, receiving up to 6 months' supply. In some parts of the country, there was a lack of supply of chloroquine even before the pandemic, with patients in Bloemfontein, Pretoria, and Port Elizabeth reportedly not having the medication for 2, 5, and even 7 months. The general consensus was that scientists and doctors provided little or no communication about this issue, and many patients were left in the dark about the matter. Next slide. The health sector has a natural leadership and advocacy role in responding to the pandemic. Going forward, to fulfill this role, I propose 3 actionable steps that the medical and science community can take to improve communication. Next slide. Number 1, monthly updates about the supply of chloroquine, either directly with patients or through a key patient advocacy group such as the Andrews Gift Foundation. Rheumatologists and pharmacists should have compiled a list of their lupus patients and send them reliable information on the risk, severity, and progression of the pandemic and the effectiveness of interventions used during the pandemic. Civic society organizations would have been another effective way of disseminating information to the patients. This could be done through social media platforms and getting in contact with the national groups who are directly connected to the lupus community. I found the information was shared amongst the science community and should have been deliberately made known to patients who were left wondering and bewildered by their inability to access the medication. Secondly, penalization of doctors who prescribe the medication unnecessarily, followed by stiff fines. Next slide. And finally, a helpline serviced by the South African Medical Association, where patients can access information regarding how this pandemic directly affects their condition, as well as answering questions they may have. I am aware that it may not be technically feasible to implement all 3 of these steps, but attempts to do so would certainly go a long way in giving patients a peace of mind without them feeling abandoned or uncared for. I and the Andrews Gift Foundation would appreciate your feedback on measures you plan to take from information gathered from the symposium. Next slide. I thank you for this opportunity to share my views and that of my fellow lupus patients.
Thank you, Daniela. That was a really powerful presentation, which represents not only your own experience, but the experience of a broad group of people who are living with a condition affected by this flick-flack in information that went on through the COVID pandemic and were directly involved, and getting your views and the views of others in the community on what this means in terms of life and health, and some concrete suggestions on how to take this forward has been hugely valuable. I thank you.
Pleasure, thank you.
Thank you. We are now going to broaden the discussion from the chloroquine focus, which is the kind of central content theme of the symposium, to welcome Anne-Marie Coriat from the Wellcome Trust in the UK. She has over 25 years of experience in planning, policy, delivery, and funding of research, and she led the Wellcome Trust's work in developing a more positive culture for PhD training, aimed at catalyzing sustainable change in the culture of research training. Her personal commitment to improve the research system is informed by experience gained in research funding and policy, but also from early experience as both a researcher, a technician, and a trainee hospital biochemist. In addition to leading the research landscape team at the Wellcome Trust, Anne-Marie is co-chair of the newly formed Research on Research Institute, Chair of the Advisory Board for the Global Challenges CRIC Africa Network, and an independent member of council for the Royal Veterinary College at the University of College London. Anne-Marie, thank you.
Thank you very much indeed, Kirsty. Hopefully the screen is shared okay and you can see the slide. Yes, all right, fantastic. So thank you very much indeed for this very kind invitation to speak at the important meeting, and thank you Daniela and Kate for two wonderful introductions. What I will do is give you a brief overview from the perspective of a funder, but as Kirsty said, it's informed by my wider career. In my current role as Head of Research Landscape for Wellcome, my work is really focused on trying to make sure that we can develop a more positive culture for the research system so that research can thrive, and so that what we can do is start to address some of the problems that Kate has identified. I don't need to make the case to this group that trustworthiness in research underpins all that we do, but I won't be able to resist it, so I'll do some of that as well. So I'll tell you a tiny bit about Wellcome. Wellcome as an organisation is an independent charitable foundation, so we don't receive government funding. We're very fortunate that we've got a foundational endowment that allows us to invest and then spend the products of that investment on charitable aims. And our charitable aims are really about improving health for public benefit. We're accountable to society for doing that, and we operate in a global landscape. This is fundamentally important in driving what we do as an organisation. So what do we know about the health of the current research system? I'll tell you a little bit about some of the work that we have done to give us an indication of what actually happened. So Kirsty mentioned the review of PhD training. This was an opportunity for us really to take a deep dive into how PhD training was operating and to figure out whether or not there were signs and signals that everything was either all okay or that it wasn't. What we did to undertake the research was the combination of literature reviews, and we worked with the community. And the community was researchers, it was institutions, and it was principal investigators as well as other funders. And what we found from this review was that actually there were a number of things which were really quite concerning. We found that actually the ways that research supervisors were assessing success was on completion, on career progression for people going into research, and first author publication. These were all things that they were getting judged for. These were not things that were then necessarily allowing the students and the researchers to go on and progress their career, irrespective of career choice. Furthermore, what we found was that actually researchers were paying the cost of this research emphasis on output and productivity. We found that mental health and well-being were considerably affected. Half the supervisor responses and similar numbers, if not more, of the research trainees themselves were reporting problems with mental health concerns. And the commonly cited challenges they were experiencing were around pressure to publish, so to get those results out into high impact journals, the fact that clarity on career prospects was not available, and a culture of working long hours. We adjusted the way we funded PhDs to really emphasise the importance of culture, and we changed our portfolio of funded programmes by over 70%. In addition, what we then did was say we need to build this evidence base further, and we need to really understand more widely what researchers think about the culture they work in. And this report is available online, and all the data are publicly available, as Kate said, so people can check our working. We had over 4,000 survey responses across the globe, most of them obviously UK because that's where we're based. The full report, as I say, is available, but what I'll show you now is a snapshot of some of the data. What we know is that the reports that came in relation to this indicate that the research system, the way that funders, the way that institutions, and the way that governments look at success in research tends to favour quantity over quality. 69% of the researchers who completed our survey reported that research rigour was considered important by the workplace. And then when you dig into that slightly deeper, 14% think current metrics have a positive impact on research culture, but 43% think their workplace puts more value on metrics than research quality. So this dissonance in the system actually starts to put things at risk. So what actually is at risk? We know that individuals are at risk. Researchers are satisfied with their career because they're dedicated to it, but we know that there are challenges and problems in terms of burnout. We know that survey results indicate that 25 to 35% of academics report facing workplace bullying, more than half the double general population. Impact of research is at risk. If what we're doing is putting an extra pressure to publish or to claim results, we know that actually that creates perverse incentives. And the example of hydroxychloroquine that Kate talked about at the beginning is a classic case in point where perverse incentive seems to have driven an outcome that is not healthy. And very importantly, as Daniela has highlighted, public trust is fundamentally important. If the way we work does not support public trust, then actually misconduct cases risk undermining this privileged position that we've got in society. And so what Wellcome has decided to do is we've launched a campaign. The time to act is now. The mounting pressures on research funding are placing existential threats on the health of the system. So what we determined to do through this campaign was undertake further work to help find solutions to what are essentially complex societal and system-based challenges. We launched the Reimagine Research campaign, and I'm delighted to say that the Crick African Fellows took part in one of the Cafe Culture exercises, and we're working with partners across the research sector to look at what parts of the research system can do to improve this culture. I'll mention ever so briefly the question about COVID-19 and culture. This is a report written by Digital Science, and what it does, I think, is give some information to back up what Kate has said about the increase in articles, preprints, and the amount of research that is out there as a consequence of COVID. You can see the numbers there. How do we ensure that all that research and all the grants are open, trustworthy and reliable? So I'll make the case very briefly now that open research is a matter of trust. I pose it as a question, but my belief very much is that it is. So we work in a system. As a funder, we can't demand trust or assume it. What we need to do is make sure it's easy, normative and possible, but we need to recognise we're part of a system. It's not just us, it's society, it's universities and it's publishers as well. Trust matters. It's a funny thing, right? It's not simply about what's in our own interests, and we know that our understanding of how and why we choose to place our trust in science has been piecemeal. This report from 2018 that Wellcome did with Gallup was a global survey of public attitudes, and it's quite interesting. What it does is it shows that trust in science correlates actually with trust in governments and judicial systems. That in itself is a wake-up call to anyone who likes to think of science as somehow neutral and separate. What we also need to know, and I think Daniela referred to this a little bit, is that household income and privilege correlates a little bit with trust in science. And importantly, actually, the other question that we've highlighted is that men are more likely to claim greater science knowledge than women, and that gap exists even when men and women report equal levels of educational attainment. What this does is illustrate we must work harder to ensure that essentially trust is there for people to quiz and question, and that the evidence support it. I'll run very quickly through what we're doing at Wellcome to support open research. We are committed to building trust through partnership. We work in a system, so we support all types of activities that help us set standards and align incentives. And the alignment of incentives is important not only for what we do in terms of how we fund grants, but also how institutions, universities, do their own recruitment. We work with networks of institutions. In the United Kingdom, there's a network of universities who put research improvement at the top of their list. And this network of research improvement leads is helping to drive change. We work with policymakers and networks. Next summer was supposed to be the 7th World Conference on Research Integrity in Cape Town. It's now going to happen in 2022. The focus there is fostering research integrity in an unequal world. And I'm delighted to say that Wellcome are a sponsor of that. We set our own expectations. We take part in concordats. We have good research practice guidelines. We've also just updated open access policy. So these are the things that Kate was talking about. What do we expect researchers to do? We expect all our articles to be made freely available. We expect publications on public health emergencies like COVID to be placed immediately on completion on approved platforms. And we want organisations to sign commitments to make change happen. We also are committed to developing tools for our researchers to make this possible. We have our own journal, Rapid and Transparent Publishing, for Welcome Open Research. There are many other aspects that other funders are doing as well. And as mentioned in the introduction, I have recently had the privilege of joining the Research on Research Institute, which is a network of 20 funders across 12 countries, looking at how we fund, how we basically improve how we fund, practice and evaluate research. And these are some of the projects we're doing. We are committed to changing research culture, but to borrow this slide from Brian Nosek at the Centre for Open Science, we can't do this by acting alone. We need to make it possible through infrastructure. We need to make it easy by developing user interfaces and having experiences that are easy for you to engage with. We need to build communities to make it normative, and we need to incentivize this. My closing statement is really, is positive research culture just our job? No, it's absolutely a collective responsibility. And I'm delighted to have been able to chat to you today and look forward to the rest of the meeting. Thank you very much.
Thank you, Anne. That was Anne-Marie. That was an amazing journey through the kind of the way people are thinking about this in forward-looking funding organizations, and I think that the huge shift that is needed in the culture of how we judge ourselves and how we hold our students and our mentees accountable for the science that they do, and the kind of outputs that we expect of them, and the way they produce their research and output and the way we do it ourselves is something which is absolutely critical to be taking forward. I think that because research in low middle income countries, and particularly in the African context, tends to be under-resourced and driven by funding from elsewhere in the world, where the science culture may be forced onto a particular research project, is something are particular challenges that we have to deal with here, and it is definitely up to us to stand up and make a difference from our own perspective, and initiatives which are threaded through the funding landscape, which is such a kind of powerful driver of what happens in real life, because power does follow money, is really important for us to see, for all of us to see, and it's really exciting to have you here engaging with us in this conversation. So thank you very, very much.
Pleasure, very exciting.
Our next speaker is Professor Jane Munro, who is speaking to us from the middle of her night in Australia, and we're very grateful to have her here. So her focus today is on science communication as scientists, and particularly in the context of social media. Certainly social media has taken on a huge role in the way people have access to communication around the science during the kind of rapid fire science world which 2020 has become, and that has advantages and disadvantages. Jane's going to speak to us from the science perspective, and following on we're going to have Tanya who's speaking to us from the science journalist perspective. So to introduce Jane is head of rheumatology.
Sorry.
Pardon? Okay, so Jane is head of the rheumatology unit at the Royal Children's Hospital in Melbourne and lead of the rheumatology research group at the Murdoch Children's Institute with a focus on juvenile arthritis. She's principal investigator of the ANS Clarity Juvenile National Juvenile Arthritis Study and Australian Arthritis and Autoimmune Biobank Collaborative. She's passionate about improving clinician well-being and strongly believes in the role of building community, storytelling, kindness and curiosity, as well as the need for integrated healthcare systems change to achieve this. The importance of leadership and mentoring training for clinicians and improving gender equity in medicine. In August 2019, along with several other doctors, she launched the Victorian Hospital Doctors Health and Wellbeing Network. She believes no one owns doctors' health and that we created the healthcare system so we can remodel it, and that by collaborating with purpose, we will improve clinician well-being. Jane also loves being with her 3 children and husband, planning events and trips, reading, playing trombone, badly she says, and laughing with her friends. So it sounds like you're just our kind of person, Jane. you're
Thanks
welcome.
for that.
Thank you.
Here's my slide.
Okay.
So the thing I was going to talk to today is around what's our responsibility in the time of the pandemic. And I'm coming from Melbourne at the moment. We're in the middle of, obviously, I don't know if many of you have seen, but down in Australia, Victoria and Melbourne and Victoria, we're in the middle of our second wave, and we've had many healthcare workers infected and many hundreds of deaths, particularly in aged care. And so we've had a quite extended lockdown. And so which has been announced a couple of days ago that the lockdown is going to continue. And so social media has proved very important throughout, I think, the pandemic to connect healthcare workers and scientists to spread information and also counter, I think, the narrative, as well as connect to communities in many, many ways. And so I think our responsibilities, when I thought of this early in the pandemic, certainly when there was this, I've got a number of slides to show you different, I guess, graphics of how this has affected people, but particularly how we, as doctors, what's our responsibility? As scientists, what's our responsibility? Oh, here we go. And thinking through, this is my hometown, so you can click through. That's just showing you Melbourne and the New Children's Hospital, and then my beach. So if you want to click down through there, you can see that's fine. And where I'm coming from, and the different phases of the pandemic, and thinking of how it has affected you. This is my dog, and when the lockdowns were announced, and this is Melbourne City. If any of you that have visited there, in the lockdowns, totally empty now. And I was thinking about 2020, and that memes have been a way of, many of you have probably shared them, and it's been a way that has connected us, because really everyone around the world is affected by COVID in a different way, whether you're a person who's a healthcare worker or not. There's a universality in this experience. But there is also then, of course, information is power, but it can also be misinformation can be very problematic, as we've seen with some of those other presentations. And scientific information, when it's used as a tool and as a power, can be used as a hammer, and it can also be used with nuance. And we know that that can be problematic. So yeah, next slide. And so, sorry, I've got quite a few, so you're gonna have to click through quickly. And for me, this is an Australian beach on the 2nd of January, and I knew this was coming when I saw my daughter was heading to China for an exchange. And these are the faces of the pandemic. So social media can be overload. You know, you can actually be overwhelmed with this, and it's the same with scientific information. So our responsibility is to know how to filter that. And this, for me, is you know, us. I'm not sure how much with South Africa you are bound to computers the whole time, and how much you're using electronic medical records, and that is spreading everywhere. But when you add in then social media, how much then you using scientific communication and being able to do that well. Particularly for me, say in pediatric rheumatology, which I share with my colleague Chris Scott, who invited me to speak, you know, there can be a real void. So for example, our colleague before who was talking from that perspective of a person who has got lupus, but now she's using her scientific communication to write children's novels and be able to educate a community and bring a community with her. That is so powerful. And so for me, I found, as head of rheumatology, and I had juvenile arthritis as a child, being able to use social media to engage with patients, families, and actually the broader community, like politicians, for advocacy, there is a really big responsibility, because if we don't do that, there's often a void and a vacuum, but also because people have a real interest in knowledge. And if you're not providing that, then who is? Is it fake news? Is it a source that's actually truthful? And how valid is it? Next slide, please. So I'll take you down a little bit of the spider web of really the internet and the real web. Next slide. And that's what I guess when you've got to understand a little bit about social media, is that pay respect to it and understand that you can get absolute blowback, and understand to be respectful of the people that you're interacting with, particularly on mediums where it's open and it's to the public. You need to know the different aspects. There was a really great presentation by one of the presidents and editors of one of the rheumatology journals at the European meeting this year, who really, and it was actually a 50-minute meeting for the trainees, outlined science communication across the different platforms and her persona, and how she curated her different ways of using, say, Twitter versus LinkedIn versus Facebook for personal aspects. Next slide. And respect should underpin, I think, the first way that you use all forms of those. Next. And I would hope, looking for truth as a scientist and as a doctor, that would be one of the things that would underpin. Now, I would also say that you don't have to fight for truth every single way, because you potentially would spend your whole day trying to counter, for example, anti-vaxxers or people that are in your specialty that want to argue with you. And you need to sometimes have boundaries around how far you're going to go and how much noise you're going to try and counter. But how you write and the things you put out there, you need to be clear about, and also what you listen to as the source of truth. Like perhaps you go back to at the start, some of the presentations, and whether you would have looked at those articles and promoted them, or would you have actually reviewed them. Next slide, please. So being aware of, you know, the what is social media, what mediums there are, how they interface and how they work. If it's too overwhelming for you, and does it just cause anxiety to actually open these? Do you have a brain that actually likes tabs open? And how would you curate these and actually make them work for you or for your specialty, for example? Next slide. And I think the key here, and the responsibility in the pandemic, the reason it was so incredibly helpful was that it, you know, I found without doubt, the people that were on Twitter, for example, in Melbourne and in Australia, we knew more than the CEOs often, than the CEOs and the executives about the evidence, the evolving evidence, what to do often, and we're more connected in our cities and in Australia with days in advance often, and we're pushing it up the tree because we were on social media and pushing things out and connecting internationally from our specialist societies, from our Twitter networks. It was actually quite phenomenally, and with the big COVID groups that formed amongst medical professionals, it was really, really fast. Next slide. And I think that was the responsibility, to make sure that we were sourcing good information and quickly. But of course, that can spiral, as you found probably with some of those publications that Kate showed at the start, that we needed to make sure that they were high quality. So Twitter in the COVID pandemic, there's been a number of publications about social media already for use in the pandemic, and some of the things that they've highlighted are there were some really pivotal role in epidemiological analyses and how they were rapidly communicated. So they pushed out outbreak genomics very early, they open sourced epidemiology, but being really aware that there's some barriers, some pretty tricky challenges and some potential wins, but you need to be aware of your conduct as a professional and how that's communicated. And particularly when there's that psychological overlay of being maybe a health professional at the front line, worried about your family and the anxiety levels, particularly when you're doing some advocacy, and how that's being portrayed in the public arena. And obviously things like there's a different role for Twitter or fast-moving social media for transmitting public health advisories, rapid situational awareness alerts. And then, of course, there's that undercurrent of malignant misinformation. Next slide. And that malignant misinformation, I think, is one of the big things where we see we need to call it out, or where we see something's really wrong. So next slide. And that's where overload can be a really big problem. and you need to be aware of where there are recurrent themes. So people are still, I will find every day, I've got a large Twitter following tagging me repeatedly on hydroxychloroquine posts and triple therapy, ivermectin. There's just there's massive sort of followings of people that want to do that. I just ignore them or block them if they become problematic. You have to have a strategy for how to deal with that. Next slide. So again, the role of advocacy. So is our responsibility for advocacy, and we've certainly had a range of health professionals that have linked in behind the scenes in WhatsApp groups that have also been involved in really quite strategic political advocacy or advocacy around health and safety. Next strategy, next slide. I would think that your responsibility to yourself is to find your tribe. It's also a bit of a joy on social media if you enjoy social media, depending what your interest is. Next slide. I strongly recommend you just take the high road and be kind always. Next slide. Just be aware of your limits and how much time you're at the screen during the day. We're all Zooming at the moment, and be aware that it can have quite a negative effect. The endless scrolling and getting involved in any kind of arguments or pulled down that rabbit hole. Next slide. We can lose this humanity in healthcare. People often think this is a really cute slide, but actually it's a horrible slide as a paediatrician. It's a doctor at the computer, and we're missing out on the great richness of pediatrics. Next slide. So, you know, social media, we have a great responsibility that can come with it, but it does provide potentially huge connection and opportunity to spread scientific communication. I've ended up on fantastic research teams and been introduced to wonderful collaborators by social media connections, including people that I've ended up having, you know, 10-year-long collaborations with internationally, which has been pretty amazing through a social media connection. Next slide, please. I think the storytelling component and to be able to connect with our patients and their families is really, really important, and that should be something that we should learn more about actually. And I've ended up enrolling in a degree in professional writing and editing this semester, which is a 2-year degree, which will take me longer than that, but to learn more about actually being able to get better scientific communication. Next slide. So thinking about what's the elephant in the room, what's not being said, what are you missing? And if it's off and it doesn't feel right, just extract yourself and press pause. Next slide, please. And make sure you draw a line in the sand. Again, if you're on social media and you're really angry about something, next slide, please, press pause. Know your institution's social media policy, and there'll be some issues where you might get close to the line, and be careful you don't step over it. Next, particularly in a pandemic where you're advocating around safety, and do not tweet or post when you're angry or when you've had a veno or two. And there's been a number of doctors that have got into strife around that, and I think that's a very good and important, or when you're distressed or very fatigued or tired around the pandemic. Next slide, please. Re-emphasize be kind always. Next slide. Know that you and how to have your mind changed, because that's one of the joys, I guess, around science, that we can be convinced otherwise and be open to that. Next slide. Social media is vast and you've got lots of opportunities, and you will offend people for sure if you're on social media for any period of time, so know how to give a real apology. Next slide. This is just to remind me to say that we're finishing up now. Coronavirus has affected everyone in the world in lots of different ways, and it's been pretty impactful and pretty devastating. So we need to all look after each other and remember that connection. Social media is one way of being able to do that. Next slide, please. I'm just going to highlight, this is one of the things that has spread by social media, which is a clinician-led movement that I helped co-found in Australia. It has lots of great resources on it, which you may find useful, pandemic kindness movement. So feel free to look that up. It's been really very, had a huge uptake across Australia. Next slide, please. And feel free to suggest any great South African resources. It's based on Maslow's hierarchy of needs and links to things that clinicians and healthcare workers might need. Next slide, please. And this quote from John Lewis, who recently died: "Do not get lost in a sea of despair. Do not become bitter or hostile. Be hopeful, be optimistic. Never ever be afraid to make some noise and get in good trouble, necessary trouble. We'll find a way to make out of no way. A way out of no way." And I think this is useful with being responsible in social media, making sure that you do try and find a way and spread your scientific communication, other communication well. Thanks for having me today. It's been an absolute pleasure. And I look forward to hearing the rest of the talks.
Thank you, Jane.
We don't need to. No, we can finish
sorry.
now. Yeah,
I'm going to other stuff. Thank you so much, Jane. I think you know, this is something that as we've had to deal with a condition playing itself out in fast forward with all the attendant differences in speed, differences in speed with which the communication channels have come out, and how we've had to respond to them. It's really highlighted all these conditions, all these issues that we've had, that the science community has been increasingly dealing with over the last decade, really, but has come into absolute hyper focus in the last 8 to 10 months. And I think really, for me, communicates how important it is for us to take responsibility for our own scientific literacy with respect to the information as it comes out. But in addition, to take and certainly to be aware of the limits, both in terms of one's ability to focus on to know about a particular content area, to be able to judge a particular content area, but also to take responsibility for one's social media platform in the context of the science kind of hyperdrive, and the reason for that is because doctors are, even if they aren't trusted by the public, they are looked to for opinion in these situations, and it works both ways. People get lionized, and they get just as easily vilified, we've seen in recent times as well. So it's necessary for us to help communication, but it is also really important to take responsibility, and it's a very difficult path to tread. So thank you very much for giving us the positive focus of social media and how we can use it to create connection between people, to allow that we all make mistakes, and that to do that and to change our minds in responsible ways, but to use it to our own positive good as well as those of our patients and population. So thank you hugely for that talk, and
you're welcome.
And for staying awake to us.
That's it. It's not that late. It's not too bad here. It's only 9 o'clock. I'm all right. But you're very welcome. And I think there is a lot of good for building community amongst clinicians and scientific community too.
Okay, brilliant. Our last formal talk of the day comes from Tanya Faber. Thank you, Tanya, for joining us. Tanya Faber is a senior science reporter at the Sunday Times and the Times Live. She has a master's in journalism from Wits University and has written 2 non-fiction books and 2 journalism reference books. She wrote Through My Lens with veteran photographer Alf Khumalo, and she wrote Blood on Her Hands, South Africa's most notorious female killers. She's worked as a journalist for 2 decades and has won local and international awards for human rights journalism work. She's carried out projects for international organizations, including the Open Society Foundation and UNAIDS, and she also hosts a regular podcast called the Kwezi Science Report. So Tanya, we're very privileged to have you here, talking to us about how our science plays out in the world of the formal media sector, and what that means. So thank you.
So I wanted to talk about science and the media, And I wanted to just, as my introduction, I just wanted to say that, as a science reporter, it so often happens to me that I write my story and I send it off to the scientists that I've interviewed for an accuracy check, and the scientists come back and say, you've really oversimplified it. And in the meantime, I've shown the same draft to my editor, and the editor says it's too complicated, which I think goes to show how, it's a real balancing act for reporters to get it right, so that you balance the science with the simplifying it so that a lay audience can understand it. So with that in mind, I've got 5 little mini topics that I want to talk about briefly. The first one is the link between political leaders, science, and the media. So I'm sure some of you recall in the SARS crisis in the early 2000s, in China, that was a real case of authoritarianism. So, Times Magazine reported, for example, that in one hospital, 31 patients were driven around in an ambulance for the duration of a visit from the World Health Organization. So we only know about that because because the Time Magazine reported on it. So that really shows an example of, politics and science and the media all inextricably linked. Then we have our current situation with Donald Trump and hydroxychloroquine, and we've discussed that in some detail today. And one can look and one can point to his stupidity, but as you've heard from the other talks, stupidity can make its way into credible science, and then you have a disaster on your hands. And you also see there the media alliances. So, for example, the way Fox News would report on something like that is very different from how an outlet like CNN would report on it. So there you have an example of a leader who's actually anti-science, but still manages to exert some influence over public opinion. And then I guess closer to home, looking at Cyril Ramaphosa and, going through the various levels of lockdown and how people have responded. And the one thing I've really realized as a science reporter is how fickle the audience can be. So, for example, the ban on cigarettes, the public has rightfully so asked a lot of questions regarding, what was the scientific thinking behind the banning of cigarettes. But then when, just a personal anecdote, when I reported on the lifting of the, the alcohol ban and the effect that had on ICUs and general wards, I got a lot of flack from readers saying, oh, that's not true. Alcohol doesn't have a negative effect on our society. So, as much as scientists are trying to grapple with making sure that there are credible processes behind what's happening, journalists are also having to deal with a public who relies on science when it suits their paradigm, but rejects science when it doesn't fit in with their thinking. So someone wants to have their glass of wine, and they suddenly don't want to hear the science about how alcohol fuels gun violence, gender-based violence, interpersonal violence, etc. So that was my first point, was the link between politics, science, and the media. And then the second point I wanted to make is the role of the mainstream media at a time like this. So you've heard from all the other amazing panelists how, science, good and bad, makes its way into the public consciousness and the public zeitgeist. And that puts a lot of responsibility on us as journalists to make sure that we get it right. And what we've definitely noticed is that there's been quite a strong swing back towards relying on traditional media as a source of credibility. Can you still hear me, Kirsty? Kirsty?
We can hear you, Tanya.
You can. Okay, great. I suddenly thought I was just talking to myself. So we saw that during lockdown, obviously the number of print editions that were sold of the Sunday Times, for example, dropped tremendously. And we began to worry, is it just because of the logistics of the lockdown that people aren't wanting to go and buy the paper? Or have people actually given up on mainstream media? But then we realized that our online stories were getting exponentially larger audiences than they had before. So we felt that maybe at a time like this, during a pandemic, people were turning back to mainstream media to try and disentangle all the noise from all the sort of the fake news out there. And so I guess, COVID-19 has left a vacuum in which all sorts of fake theories and conspiracy theories and bits of fake science have blossomed, and it's our role as the mainstream media to be the ones asking those questions of what's reliable and what's not. It would have been very easy for a science reporter to pick up on the hydroxychloroquine study and then amplify it. So it's our role to also be a kind of a gatekeeper for the truth. And then I guess, going back to what Jane was saying about social media, is that one hopes that social media will be amplifying the accurate stories that have been written by credible mainstream media, instead of giving the same amount of amplification to, one person's experience with a more credible source, where a journalist has actually done a lot of work to make a story full and rich and accurate. And then I spoke earlier about, the balancing act as a science journalist, to get it right, to make sure that you haven't made it too simple and lost a lot of the scientific nuance in the process, but at the same time, it has to be accurate, and it has to also be accessible to a lay audience. That's what I'm trying to say. So I guess at this time of COVID, I guess what's been the most challenging for us as science journalists is to get the balance right, even as the evidence changes. So, normally we report on something and, there's the true story and there's the fake story, and it's quite easy to tell the difference. But at the time of COVID, the science itself keeps changing and the evidence keeps changing, because the world is still fumbling through the darkness of COVID-19. So, for example, I'll just give you some examples, whether the BCG vaccine can play a role, whether weather and climate are playing a role in transmission, whether herd immunity is just a pipe dream or can actually happen. So as there are new papers written, we report on those. And then we get readers going, oh, but last week you said that the weather didn't play a role, and now this week you're saying that the weather did play a role. And our role as science journalists is to go, no, we are not saying that. We are reporting on the different studies that are coming out. So we have to rely on the scientists to be doing all their proper due diligence that what they're putting out there is real and peer-reviewed. And then it's up to us to share that information. But I must say, during COVID-19, it does mean that we're sometimes reporting to very opposing views or bits of evidence on the same topic. And I guess we also bring our own beliefs and biases and assumptions to the table. So, whether a journalist likes to admit it or not, sometimes we feel compelled to write a story because it fits in with what we believe. And sometimes whether we admit it or not, we feel less inclined to write about something if it doesn't agree with our view. An example of that is the wearing of masks, which is now, you'd have to be an absolute fool to think that it's okay to not wear a mask. But it was quite confusing at the beginning when the World Health Organization was putting out quite mixed messages about mask wearing. And someone like me, who right from the beginning felt it was absolutely crucial to wear a mask, it was quite hard for me to include that voice of the World Health Organization saying that, they weren't sure yet if mask wearing was a positive. So somebody else, one of the other panelists have mentioned the anti-vaxxer movement, and I think there's a lot to be learned from the MMR vaccine mess up that happened, and the effects that has had on public health. And the reports have shown that just a tiny handful of tweeters managed to win the anti-vaxxer war by playing on fear rather than science. And there's so much to be learned from that. And a few months ago, I wrote a story about some work that Francois van Schalkwyk, a PhD candidate at the University of Stellenbosch, was doing. And he actually mapped how the anti-vaxxer movement had grown from social media. And there were very, honestly, you could count on your one hand the people who had initially put out the anti-vaxxer messages. And then you just see this kind of this amplification of these dots on the map of this one tweet just being retweeted and retweeted and retweeted, and then believed by so many people until you've got a public health crisis on your hand because something like measles starts spreading again. So I just want to quote van Schalkwyk here. He said, it was a tiny group of people who used whatever mechanism they could to amplify their messages. and they use Twitter to create hype and controversy rather than to spread science. So info gets circulated very, very, very quickly, and it's taken at face value by a lay audience, whether it's actually true or not. So I remember when I was writing that story, I phoned a private baby clinic down the road from me that does vaccines to get comment from them. And they were reluctant to comment, and I was surprised by that. I thought they'd be very keen to comment and go, oh, you know, anti-vaxxers are crazy. Of course, you know, everybody, all babies should get the MMR vaccine. And the nurse at the clinic explained to me that they don't want to comment because the people who they are able to really get to are the hesitant people. So it's not the people who were militant against vaccines or the people like me who are militantly pro the science behind the vaccine to say that you should have it, but it was the people who were hesitating. And I guess, you know, there's a bit of an echo chamber with like-minded people, and I think that's what the baby clinic was aware of, and that really gave me pause for thought as a journalist is, you know, to try and nudge and convince people rather than coming, you know, I think Jane said earlier, a hammer versus a nuanced approach. One has to come with nuance to try and get people to understand the science rather than belittling them for spreading fake news, even though, you know, the desire might be there to do so. And so just for my last point, I wanted to talk about the issue of the COVID-19 vaccines that are under development and what we have learned from the MMR vaccine controversy, or not controversy, but the mess up that happened. And I think the most important thing to understand is that people will latch onto fake science if it taps into a groove that they already have in their mind. So, you know, for a lot of people on our continent, the brutalities of colonialism and apartheid are, you know, obviously alive and kicking and are very fresh in people's minds. So when someone comes along and says, you know, Africans are being used as guinea pigs for vaccines, it's not a big leap for a person who has experienced, or an older generation in their family who's experienced the brutalities of colonialism. It's not hard for them to make that leap from what they've experienced to believing the fake news that, you know, Africans and nobody else are going to be used as guinea pigs. And yet the scientists are saying, if anything, we should be more concerned that not enough trials are being done in Africa. So you have this, you know, this absolute dichotomy between the public believing that African countries will be used as guinea pigs and scientists going, no, we want as many clinical trials to happen here as possible, but with all the checks and balances in place so that we also play a role in the development of the vaccine and therefore increase our accessibility to the vaccines once they've been you know, produced and manufactured after they've gone through they've jumped through all the hoops. So I just wanted to end off by reiterating the point I made earlier that, you know, that my role as a science journalist has to be a gatekeeping role, but I also have to rely on the scientists to, you know, when I hear the story about the hydroxychloroquine study, making it into a journal without the proper checks and balances, that's horrifying for a journalist because we rely on the scientists to tell us the accurate information so that we can, you know, probe and prod and ask if everything's right. But we also need to know that the information that we are simplifying and amplifying to a lay audience is accurate. And I always think of the nurse at the baby clinic who said that, you know, it's the hesitant people who you need to try and convince rather than hitting people over the head and going, that's fake news and that's real. Rather, you know, to say to people, here's a compelling story, this is why it's a true story, and this is why it's important to have accurate information at all times. And my role as a science journalist is to try and be that bridge. And that's it. Thank you very much.
There. Okay, so I may speak again. Tanya, thank you for taking us through those really important points. I think, you know, particularly the science and health journalists, obviously as it relates to us, plays this critical in-betweener role between the scientists and health practitioners and the public and the politicians and policymakers. So it's you've got you're a kind of central hub that that speaks to all of these people and has avenues that reach all of those groups. And I think, you know, we all recognize that often people, be it lay people, be it medical people, human beings, attach more value to the first story they hear about something.
Yes,
they tend to believe that first story they hear, which is why the MMR vaccine one of the reasons why the MMR vaccine has been such a kind of tenacious opponent in the science story. I think, and as you say, because it taps into our worst fears about our children, and that's the other thing, is that when it reaches vulnerable people, it has additional traction. And the thing about the COVID story is because everybody's vulnerable in COVID, really, as in it reached the whole world. Not everybody in the population is as vulnerable as the other, but at the beginning, people didn't know. We didn't have this information, and it's only just coming out now. And so people were hugely invested in finding out about this. And the story is complex, and human beings are complex. And being able to communicate what is known with nuance and be able to communicate some level of process so that people are prepared if things might change tomorrow or next month is a kind of a huge cross to bear, I guess, in a way. So thank you very much for sharing those really, really important thoughts with us.
Thanks for inviting me.
Yeah, thank you. I'm so glad we got you working.
Yes, me too.
Maybe I can ask Jane if she's been involved in setting any of the policies around social media in her institution, because I mean generally these policies come to the fore when things go wrong, when somebody has made a post that is, you know, unraveled and caused a lot of controversy, but in fact, yeah.
I was really involved, actually, way back before I was involved with social media, involved in the quality unit for a very brief period of time in writing policies and procedures as in a different life, and I was involved with some of that as one of the chief leads, and then, in fact, I was saying to Chris that I learnt when the Grand Prix was about to be on, the Melbourne Grand Prix in the March long weekend, there were a number of us in Melbourne felt very strongly that should not go and have 250,000 people having a big public event when the case numbers are going up. And I got we had a quite strong group of doctors around Melbourne making a decision that we would be very strong on the Thursday, Friday before the Grand Prix, that we were actively lobbied by people because we had strong social media presence to be very active to try and convince the political people in town to not go ahead. And there was a massive fine that was going to happen to our government if they went ahead, if they cancelled the Grand Prix versus the Grand Prix people. We found out later, and I found out myself because I went pretty close to the hospital's social media policy of how strongly I was advocating. And so I myself, Kirsty, was finding out that that's why it's one of the things, and a number of us were being aware of how close. I actually spoke to our comms person at the hospital as well, so that's one of the other things, that is being aware of having that relationship with the comms person in your organisations. And in fact, various people have actually done that in collaboration with the communications and media team over this time too, about getting that relationship right. And sometimes that hasn't worked out very well. Sometimes healthcare workers have felt that they haven't had that collaboration, and they've actually felt like they've been silenced early on, even when they haven't really done a lot of very vocal advocacy. So actually it's quite hard. It depends on sometimes not even the policy, it just depends on the approach. Some organisations are just like, we don't want you to have much social media at all, and others are very liberal about it. So it actually depends. And some research organisations, for example, really rely, you just give me a nod if you've got someone there ready to talk, but some research organisations, and the Murdoch is great at this, the Murdoch Research Institute where I work, and a couple of the others in Melbourne, they really support the clinician researchers, for example, or other researchers. If they've got a big social media following on Twitter or LinkedIn and others, they will really like them to promote their research in their lab, and curate that and work with other labs and other researchers and bring that work together, because they can collaborate and work together with the Research Institute. And they'll actually often do media training and support them in how to do that. And I think it's a really good way to help people be able to talk about science as well and engage all different types of people.
That is obviously a really a good way of communicating information in a responsible way. I wonder if any of the other panelists would like to comment on that. Anne-Marie, I know that Wellcome Trust has a very active social media policy and presence, and uses it in a positive way to try and get information out there, information about their fellows, information about research findings. Maybe you'd like to comment.
Excellent. Yeah, no, delighted to comment. So, I mean, in relation to the question, having abstracts out there and lay summaries is super important. I mean, that's one aspect of transparency, but I think there's so much more. There is the data that's collected, as Kate has alluded to. There's the way that different algorithms are put together. There's all sorts of questions about how various experimental plans are shared, really trying to make sure that all research that's funded is findable, accessible, interoperable, replicable, and assigning sort of persistent identifiers to allow that sort of analysis to become much, much larger and for people to find the information. We're actively discussing this at Wellcome at the moment to try and improve culture, and we think, you know, actually there's more we can do. Funders are beginning to question what sort of statements they ought to be asking applicants at the point of submitting grants. Things like, you know, what have you used from others that has helped you to change your mind, to, you know, refine your ideas, and how much do you know about whether your research has been used by others, so that you're actually normalizing the importance of this. But quickly coming to your comment, Kirsty, about Wellcome and its social media, yes, we actively support our researchers to do this. And the explicit important thing that we do there is that we don't use necessarily our own corporate account to do the routine science communication. We absolutely want to empower our researchers to be doing that, and then we amplify that, etc. So I think it's that sort of partnership, and it's really making sure that we are developing that trusting relationship and that you're getting the most accurate engagement from researchers on the ground. So Jane's talk was absolutely, you know, absolutely spot on.
And I think, I mean, the other element obviously is that if you engage with the people and the communities who are being focused on in the research right at the beginning, so that it is not just a conversation about communicating your results, but a two-way conversation during the development phases of the research questions, all the way through the research and through to the end, then you actually have a relationship, and that it's much easier for everybody to be able to communicate, and there's already some level of trust. So I think that is also a very important element to bring into things.
I would add just very quickly that we'd be negligent if we weren't taking the population's view that we were researching for into account at the beginning. I think that would be an absolute mistake.
I think we've got a couple of comments here. I think the first, I'm going to repeat the question that Valerie has asked to Anne-Marie, and Anne-Marie has responded in the chat, but I don't think everybody's seen it, so I'm going to let her speak to the question. So Valerie asked how. She's asking to Anne-Marie at Wellcome Trust, how do you manage the changing landscape of evidence and truth which is obviously very, you know, a difficult concept. What was true, what was in fact believed to be true in February is not true anymore. And how can the public navigate the changing information which casts doubt on reporting? Lay folks don't always appreciate that information. Oh, sorry, this is from Goodman. Lay folks don't always appreciate that information changes as evidence evolves. Is there anybody else on the panel who would like to reflect on that over and above what we've discussed?
Don't worry about it.
Tanya, I think maybe you've spoken to this in quite a lot of detail already, and I mean, what I hear from everybody really is that, you know, we have to stay humble, we have to stay kind and not adversarial in our interactions, and we have to let people see some process where we can, so that it's possible to change direction if needed, because, you know, otherwise we would never progress if everybody held their position.
Maybe I can just add one thing to that, Kirsty, which is, you know, I think for people to be aware of their own confirmation bias, you know, and people look for articles that confirm whatever view they have. But once you know that about yourself, I think it's easier to open your mind up. And for me, the most, you know, if it wasn't so sad, it would be humorous, is how Sweden gets wheeled in every time someone's trying to make a point. So, you know, you have people going, Sweden is proof that herd immunity works. And then other people going, oh, I mean, look what happened in Sweden, you know, herd immunity is a myth. And I'm sitting there going, how's it possible that one country and what happened there can confirm two such opposing views, which just shows the confirmation bias that we as human beings carry.
I think the other, I was going to say, I think the other thing is being really aware that you know, every time we all carry around our phones, and a little bit goes to what Anne was saying, and I said, Tanya, we have algorithms driving every single thing, you know, and the fact that I can go from everything to having talked about, you know, platypuses on the walk home with my children, and then Facebook is suggesting platypus farms and buy platypus feet, and do I want a platypus? Like, really? And you know, a post from my friend from 5 years ago about platypus. No, I don't want to know about platypus. But equally, the same thing with science. You know, you will go to the same sources. You will have those, and you will be in an echo chamber of the same political parties and the same sort of feeds and the same things in your papers. And so I deliberately try and find people of different political slants, but also different views. So I will follow people with different scientific views, and I will try and find that on social media channels too. Not ones that actually make me feel too toxic, unless it's kind of funny. But I think that's actually really important to actually seek that out and then look for some of those opposing things that challenge your thinking. And I think we should do that anyway, really, shouldn't we? Scientifically, that's what the good thinkers have always tried to do, and we sometimes have lost that debate. I always find in the research institutes, when we've got visiting speakers or some of our really good thinkers, they're the ones that will get you to think differently and challenge your theories, and I think that's a good way to be able to present an argument anyway.
Thank you. I think Kate, did you want to say something?
Yes, just sort of the concept of truth and us being able to find the truth a bit easier. I think as clinicians and as scientists, but mostly clinicians, I think we often don't understand how to read data and interrogate it, and, you know, to find that truth in it. So to create a better awareness of ourselves, to examine our own bias, to examine, you know, groups and compare groups, to see if, you know, like a checklist of things that can make you understand a paper a little bit easier. Because if we can't interrogate data well, and I think most of us are trained that if it's in a journal, it must be true, you know, someone's reviewed it, but that we approach things with a much more critical mind, because if we can't find truth in papers, how can we expect that of the public? And similarly, through that, increasing scientific literacy among clinicians, but equally, you know, making it more available to the public so that people can start to interrogate data on their own. And there are some useful resources online. Elizabeth Bick is someone who interrogates papers, and they fact check all science and literature, which I think is a very useful. Within 2 days, they had fact-checked the original Diderot paper and shown up those problems. So I think we need a much more critical view and not this sort of assumption that all science is good science.
Thank you. The last question I'm going to do is Valerie's question to Anne-Marie, which I'm going to read out. Thanks for the great work you're doing at Wellcome. And Rory, can you give us a sense of how the changes in research culture which you're trying to bring about are impacting on the way in which funding decisions are being made by Wellcome and other funders? While it's laudable to emphasize the importance of other contributions, my impression is that researchers are still judged largely by the number of publications they produce and the journals in which they are published.
So, I mean, thank you. A hugely important set of questions. There's quite a lot to unpick in that. It's quite a complex environment. And I think this is something that we just need to bear in mind, that change won't happen overnight. And this is not a job that we're going to have completed by next year. We are at Wellcome setting out a 10-year agenda, as we are with the other research funders. There is actually quite a lot going on to find ways to better assess a wide range of contributions. And I think that comes to Kate's point about being critical, about not just accepting facts. So when we are asking our reviewers to do things for us, we are highlighting that actually we want to have a better range of contributions that they are assessing. Rory's got a project which is going across all funders, looking at how we're defining excellence. That's going to be a baseline almost to help us understand what we are doing and what we're not doing. When it comes to publications, yes, we have in the past historically gone for the impact or the what have you. There's a much broader range of metrics we can use, and at Wellcome we are advising very strongly, in fact requiring our panels to be fully cognizant of what the San Francisco Declaration on Research Assessment indicates, which is journal location does not carry weight, should not carry weight. In 2021, our policy will change. Institutions who apply to us will need to have signed up to that or something similar. The question is then how we do the assurance. We're also increasingly looking at how we can use things like credit taxonomy. There is a network across the globe that has looked at how you look at contributions that researchers make to a whole range of research activities, producing code, producing data, doing analysis, etc. You know, communications, engagement, and how we make sure that we are counting that. We can do a whole lot better in all those sorts of things. I'm happy to share and produce a brief summary, which you can circulate later if that's of any use. But that's a quick
Can I ask a cheeky question of Anne-Marie while we've got her? Can I ask, given Wellcome has such massive international impact and we often follow a lot of their lead, what are you looking at doing to ameliorate the impact on females and the probably unequal impact COVID has had on their research output and the huge impact of all the lockdowns and COVID for women in particular who are at home and often taking the burden of caring role?
Hugely important question, and I mean, this is where an organisation or a network like Rory can have a fantastic impact. You know, we've got 20 funders across 12 countries. At Wellcome specifically, just last night we were agreeing how we were going to approach these things for the applications that are coming in and are going to be triaged next week. We have highlighted, and again I can share some of the words that are out there, that COVID will have had a disproportionate impact. We should use the full range of outputs that are available. We must absolutely not delay consideration and ask somebody to go back and produce extra prelim data as a consequence. We should also make sure that our panels are very, very clear and are taking into account that a neatly packaged publication is not the only output. In fact, it is only one output that people can submit and report against. And we should take into account the full contributions that people have made, you know, running the projects, developing the data, the code, etc. And that is very explicitly written into something that is going to be used next week. That type of thing then needs to be shared across funders, made absolutely transparent. And we mustn't assume just because we've said it, it'll happen. This is something that we need to keep a really close watch on and pick people up when they appear not to be using it, and make sure that we're briefing individuals when they're coming in to do our assessment and not assume that it's there. That will be a long journey, but It's very, very important.
Thank you.
Thank you. We're going to hand over to Lionel now, our Dean at the Faculty of Health Sciences, who's going to just make some closing comments.
So colleagues, thank you very much. And I suppose in many ways this is, am I okay to go? Hang on.
Not seeing you.
Yeah,
Okay.
I'm just sharing my webcam. It won't be the same problem as before. But colleagues, maybe thank you for your contributions this afternoon. And I suppose this is an opportunity for me to say welcome to the faculty. In fact, none of you is on the campus at all. So it's quite a powerful statement for me that you're not here at all, and yet you've been here so powerfully. I also want to take the opportunity to acknowledge humbly, I suppose, the fact that this is an all-female panel. I'm sure Kirsty didn't set out to do that, but it is the power of women in authority that changes the nature of the way conversations happen. And so I want to acknowledge that, Kirsty, very powerfully, because it's part of the reason why I hesitated to contribute earlier to the conversation. But I think that John Lewis quotation struck me quite powerfully, that we will make a way, we will find a way to make a way out of no way. And I think it speaks so for him as a person who's just died this year, but one of the youngest speakers at that march to Washington speaks very powerfully about how the many ways that we need to create in all of the environments that we're in. I do want to say a couple of thank yous at the beginning, and I want to thank Kirsty particularly, because in many ways this conversation is the maturation of a debate her and I had right at the very beginning, where I think we had gotten ourselves into trying to tell a single story. And what happened is that additional voices were being added to that story, and how we navigated that space, I think, is the culmination in this seminar, and I'm really grateful for that journey. I want to just acknowledge the role of the Professional Standards Committee, because in many ways that represents the faculty's attempt to ensure that our behavior as professionals within this space is not at odds with the desires of a community around us. So just a couple of remarks in terms of this afternoon, and I want to do it in three parts. I want to pick up some of the key themes that people have made in their talks. I want to raise the themes that I think have captured the essence of the conversation. And then I want to reflect a little bit on so what? What does it mean for us going forward? One of the things for me that's been key in this pandemic time is really the extent to which the health services and the health professionals, as well as many of the cross-sectoral entities which have engaged in this process, have had to reflect on our own vulnerability. And in many ways, the extent to which our vulnerabilities have caused a bias in the way we've behaved and conducted ourselves. But in many ways, the pandemic has allowed us to reveal our capacity for uncertainty and the implied adaptability that we've had to create as a consequence of that. I wanted just to pick up just a couple of things from what people said, which I think may represent the axes around which this conversation of science and the community happen. I mean, from Kate's talk, I was quite interested in the fact that the Pope sent somebody to find a cure. It's quite an intriguing idea, and I suppose a bit of a reflection on religious colonialism in some way. But for me, the two powerful axes around Kate's talk is this idea that the level of dishonest science versus the inappropriate governance and scrutiny of that science, both before it's conducted and after it's conducted. I think those are things that we have to reflect on quite powerfully. I want to acknowledge Daniela Jan just because I think the patient voice in these conversations is crucial. And I think that the voices that we permit into the room, and I use the word permit advisedly because institutions like ourselves must reflect regularly on the extent to which we're centralizing the community voices that can speak quite powerfully to all of the conversations that we're having. But I thought Daniela's, Ms. Jan's comments on the suggestions of how we go forward, I thought were around three ideas. the importance of communication and regular communication. And then this notion of a patient calling for the accountability of the professions that serve them. This idea that there must be consequences for people who misbehave or take a non-evidence-based approach. And then the last one was this idea of support, which is going to come through the call line, the hotline that she spoke about. Anne-Marie Corriott, I really appreciated this idea of a funder speaking to this health for public benefit, because I think in the questions that came afterwards, I think one can still see this notion of how do funders determine the agenda, or how do they respond to the agendas? And I think this health for public benefit is an important idea when one speaks about the networks of networks, perhaps, and the extent to which the public is in fact part of that network. I was quite struck by her figures that showed in that research study that 43% of places preference the metrics over the quality of experience in the research process. And that's maybe an important question about how we engage with this quality versus quantity discussion going forward. I want to thank Jane Munro for that really refreshing view of this discussion on social media and the capacity that we as health professionals and scientists have the capacity to remodel our health systems, because in fact we're a part of them so integrally. And thank you again for foregrounding the notions of kindness and the idea that it's something in a quantity versus quality paradigm. Kindness is often neglected, and then it echoed, I thought, the importance of while we're looking in the pandemic to be particularly kind, there may be other things which are adversely affecting people's state of mind and mental health well-being. I'll take away quite strongly from that talk the two statements you made towards the end about know how to change your mind and how to give a real apology. These are two notions that so deeply affect our engagement in the health space, but increasingly are a part of a social problem in South Africa, that we don't always learn very well how to change our minds, but particularly we're very poor at giving proper apologies. And then to Tanya, I want to just acknowledge this struggle, because I have to say, I saw the media in a different light in the conversation that you brought to us today, and this tension between balance and nuance, and particularly the struggle that you must have faced, or you have faced, in this rapidly changing environment where truth itself is different one week on another. And I enjoyed the example of the masks particularly. So colleagues, there are a couple of themes that I think have emerged from these conversations today. And the one I have to say for me, and I come from a social accountability background, it is this question of accountability. And I think the accountabilities that have emerged through this conversation are based in our relationships between sectors, both within a sector and the hierarchies that may exist within a sector, but also the hierarchies that happen across sectors, health professionals versus patients, within disciplines versus each other, patients versus their providers. And so accountability, I think, is a strong idea that we need to reflect on. Some of the axes in there were the tension between funders and the researchers, the tensions between researchers and the journals in which they write, the professions and the community, and then this notion of achievement versus well-being. The intersectoral nature of our response to the pandemic, though, is something that I hope lasts in how we communicate in the future. This notion that there are many sectors which have contributed to our successful management, and successful management hasn't been complete stoppage, but even that idea of successful management has been an adaptive idea over time. I think that within that intersectoral engagement, the pressure to change our culture, and there are a number of cliches speaking about how we will refer to this time of pandemic and our emergence from it. But what is very clear is that our changing culture must reflect on the reconstruction of power dynamics and power relationships. And I like the comment in one of the talks that positive research culture is in fact a collective responsibility. So to conclude, colleagues, I want to ask the question about so what? The pandemic has shown us the quick transitions we've had of a given truth, the evidence arriving, and a changed truth. And I want to reflect on these in terms of the mandates of a university. But I want to start with the African saying that has characterized Ubuntu over these many years. Umuntu ngumuntu ngabantu. A person is a person through other people. And I think you've reflected as panelists and in the choice of the panelists today, the extent to which that is clearly an underlying theme that we must keep in mind as we communicate the health issues and the scientific basis for those with people outside of those communities. If one examines the mandate of a faculty like ours and universities in general, this threefold mandate of teaching and education, I think in the education space, we must become aware of our communal, of our collective responsibility, but also our responsivity to the communities around us. In the research space, I think the challenge is that we ask the right questions, do the right work, and then translate our knowledge effectively to the communities who will hear it and ensure that they hear it effectively. And then in the service area, to be continually asking ourselves, how do we communicate? What difference do we make? And if we are making a difference, how do we communicate that to each other? And then more broadly to the communities that we're engaged with. Colleagues, what you've reflected for me today is the fact that the pandemic has caused us to change the story repeatedly. But often the story has changed effectively because we have listened to the many stories that people are telling. And I think in doing that, we've managed the complexity of the epidemic by revealing our adaptive nature. And that itself is an important thing to communicate. So I really want to thank the panel. I want to thank Kirsty for the organization, and to thank Goodman for kind of managing us through the process, and for Tanya for staying the course when it looked like it would all break down. Thank you for hanging on to the conversation and coming back repeatedly. Colleagues, thank you very much, and looking forward to continuing this conversation. Thanks, Kirsty.